Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, and all distinguished guests. And also, let me introduce myself. My name is Tommy Chokro. I'm from Bloomberg TV Indonesia, and I'm honored to be here as the moderator of this next discussion. So thank you very much to AmCham and U.S. Chambers of Commerce, and also embassies. Thank you very much. So welcome to the Meridien Hotel for this excellent event. And this event has a goal of how to build Indonesia's competitiveness in terms of business investments in sustainability, CSR, and inclusive growth. And for this opportunity, we will be focusing on how to create a dynamic partnership, improving health and wellness. And we also want to discuss what are the highlights, innovative corporate responsibility and sustainability programs, including explore the role of public and private sector and governments doing a teamwork in addressing economic sustainability and inclusive growth challenges in Indonesia and also APAC. So before we begin this discussion, if I may, to present these titans, if I may say, the speakers. So first of all, Her Excellency Dr. Nasfiah Mboi, Minister of Health, Republic of Indonesia. Dr. Fikri Isaac, Vice President Global Health Services, Johnson & Johnson. And Dr. Agung Kusumawardani from University of Indonesia. And the last one is Dr. George Matthew, Executive Dean of Pelita Harapan University, Faculty of Medicine. Good morning, ladies and gentlemen. So to start the discussion, before that, if I may to present, to open this discussion to Minister Mboi to give her first remarks. Yes, the presentation, so please. No, can, yes, thank you.
Ladies and gentlemen, it's a real pleasure and honor for me to be here with you. And I'm not used to such an august audience, actually. I'm just a doctor. But I did prepare a short presentation to show you where we are, to share with you our progress as well as our constraints, and where we are, and how we can partner together. Next slide, please. I have prepared this outline for slide, please. Mana? Ini. Yang depan. Aninya di mana? I don't know, how much time do I have? Thank you. Let's go to the next slide. Next slide. Okay, in 2004, about 10 years ago, slide yang mana ini? Yes. What do I do? This one. Okay, so 10 years ago, we started with this commitment with Law Number 40 of 2004, where we said what we'd like to do is to synchronize implementation of social security in Indonesia with the purpose to guarantee protection and social welfare for all in Indonesia. The programs consist of actually these 5. The social security system. The law stipulated the social security system, which encompasses these 5 programs, which is the health insurance, work accident insurance, old age pension, public pension, and life insurance. And the concept actually is, first of all employed citizens in formal or informal sectors and have income shall contribute to the program. Second is that the basic benefits are guaranteed. Third, that those who wish more protection are free to purchase additional services on commercial basis, which means for health insurance, of course, the commercial health insurance companies will not be eliminated. They will be recognized and we will be working together. Fourth is gradual implementation. We will be starting on the 1st of January of 2014, and then we will have a 5-year period until 2019 to get to universal health coverage. And the government role as regulator. At the moment, let me share with you, this is where we are as of June 2013. 176.8 million of Indonesia's people are covered under one kind of health insurance. I will be talking only about the health insurance, of course. Which is the first one, the largest, is 86.4 million people, is the Jamkesmas. This is intended for the poor and near poor, where the government pays the contribution for the premium. Jamkesda, 45.6 million of 16.7%, is paid for the contribution for the healthcare is paid for by the local government. And I will talk about that later. As some of you may know, the civil servants, since about 20 years ago, had the health insurance for civil servants, for the military, police, as well, and that has come now to almost 18 million people. Besides that, the poor, the premium is paid for by the government, central, as well as local government, while these, we pay 2% of your salary, and the government pays another 2% on top of that. Jamkas Tech is for workers. Workers, where they also pay cost share between employer and employee, and company health insurance, of course, is the big companies. I'm sure some of you already have company insurance in your company, and then the commercial insurance like the ones we know. Okay, I've been going too fast. So this is the percentage at the moment. 28% are still uncovered. All of these are covered. This is the Jamkesmas, paid for the poor, paid for by the central government. This is the Jamkesda, the local government, and the rest state. Provincial-wise, in December, at the end of 2012, already 9 provinces have universal health coverage. 5, or actually 6, are above or same as the national coverage, which at that time was about 69%, and the others are working towards it. Let me share with you a little bit about the policy and design of the National Social Health Insurance Scheme. The legal foundation consists of the Constitution of 1945, and then the Act of number 40 of 2004 on the National Social Security System, what we call Sistem Jaminan Sosial Nasional, SJSN. And then we started the preparations, and then by 2011, the regulations 2010 actually, it became more intensified, and the Act of number 24 of 2011 on the Social Security Agency, or Badan Penyelenggara Jaminan Sosial, which determines that stipulates that all these national health insurance schemes will be managed by one social security agency, which is called the BPJS, by two actually. One is for health, and one is for the others, like pension, old age, work accident, etc. And then by 2012, the governmental decree number 101 established or stipulated the beneficiaries of the government subsidy, or what we call penerima bantuan iuran. These are considered the poor and the near poor. This is an integral part, actually, of the comprehensive government program for poverty alleviation. As you may know, for poverty alleviation, we have a comprehensive approach with income generating activities, scholarship for the poor and all that. And one of that, food for work, and one of this is the free treatment, with the logic, of course, that poor people should be given the opportunity to have financial security when they are sick. Because if they're sick, they cannot work. If they cannot work, they cannot bring themselves out of poverty. So this one, the Jamkasmas and the Jamkasda, actually are part of this comprehensive poverty alleviation program. And then Presidential Decree of 2015 stipulated about the social health insurance scheme itself, and then other regulations are now in progress. We have done, as of 2012, we did a roadmap. First of all, this is only one of the roadmaps, which is stipulating about the membership. Oops, excuse me. Okay. Which is that by 2014, when we launched this program, we are counting on 86.4 million poor and near poor who will be joining the social health insurance scheme. But besides that, in 2014, there will be the transformation from 4 existing schemes to the BPJS Kesehatan, which is Jam Sostek, which is the health insurance for the workers, Jamkasmas for the poor, and the health insurance for civil servants, military, and the police. All these 4 will be integrated into one social security agency, which we will call BPJS Kesehatan. And that is what's going to happen on the 1st of January 2014. And then from 2014 to 2019, there will be a gradual integration of Jamkasda into the BPJS Kesehatan, and the membership expansion from to big, small, and micro enterprises. Consumer satisfaction measurement will be done every 6 months as of the 1st of January 2014, and the benefit package and services will be reviewed annually. We also have a roadmap like this for the health facilities, for the human resources, for the medical, for the drugs and medical devices. But I will not bother you with all those details. The membership. We have 2 categories. As I already explained to you, the first category is people with incomes below the stipulated poverty line. The premium or the contribution is paid for by the government, central as well as local, and all others pay the premium. Cost sharing between employers and employee, including foreigners who work in Indonesia for 6 months or more. But the benefit package consists of personal health care, but covering promotive, preventive, curative, as well as rehabilitative services. So it's a comprehensive care, and the benefit package includes both medical and non-medical concerns, such as hospital accommodation, ambulance, etc. And the regulation also stipulates services covered because, of course, if I want plastic surgery to be, or beautiful eyes, or beautiful nose, etc., most probably I need to have commercial health insurance, not the national one. The contributions, okay, I have explained this. The healthcare providers and payment methods. This has been a very good exercise to also establish the system, because before, people think that the best services are in the hospitals. So everybody wants to go to hospitals. We have regulated that and have the pyramid with the primary care services, where we expect about 60% of health promotion, prevention, as well as basic health care will be available for about 60% of the population. And then those who need referral, we have established the first referral at district level with hospitals type B or C or D, and at provincial level, the top referral hospitals, usually they are also university hospitals. And so the system of referrals is now being established. I will not say it's already perfect. We still have problems. Changing the mind of people is not that easy, because people all like to go immediately to the specialist, and of course that will be disastrous. And as for the payment methods, what we're doing is, for the primary health care, is capitation, which means like managed care, where one institution, like one public health center, for instance, they are responsible for a population of, let me say, 10,000 people, population, 10,000 people. They are paid capitation, just say a number, 3,000 per capita, so they will receive 30 million per month. So it is to their benefit to do more on prevention and health promotion, so that less people become sick, that they will benefit from it. If they wait for people all to become sick, they will be sorry. While at secondary and tertiary healthcare providers, we're using the ENACBTs, which is the case-based groups. That is by diagnosis or by intervention, where we know from international experience that this will lead to more cost-effective quality care, because it's much more regulated. Administration and management. As I said, it will be administered by the BPJS Kesehatan, so the single payer, who will be managing the members, the healthcare providers, claims, complaints, etc. The government, which is the Minister of Health, Ministry of Finance, and the Dewan, which is the board of the Social Security, National Social Security Board, will monitor and evaluate the implementation, and the Minister of Health, in this case, will set the regulation on delivery of health services, drugs, medical devices, tariffs, etc. So this is the scheme where the government, or the Ministry of Health is the regulator. The BPJS Kesehatan is the Social Security agency, which contracts the healthcare providers, pays them, but also receives the claims. When at the same time, they will also receive the contribution from the members and manage the complaints. While between members and the healthcare providers, of course, this is delivery of service and utilization of service. Let me now share with you where we are and the preparations. Where we have established 6 task forces who are each responsible first for the preparation of the health facilities, referral system and infrastructure. The second is responsible for the financing, transformation of program and institution as needed. The third is task force is concerned or responsible for regulations. The fourth, human resources and capacity building. Five, pharmaceutical and medical devices. And the sixth is socialization and advocacy. I know most people are interested in the first, so I'm going to share with you where we are at the moment. This is the data of May 2013, which is the preparation of the healthcare providers, strengthening of referral system by regionalization, as well as procurement of medical devices. In May 2013, we had 90,389 general practitioners, and if we calculate the ratio per 100,000 population, we have 36.4 almost, which is, while our standard is 40, one GP for 2,500. Specialists, these are the basic specialists. This is pediatrics, internal medicine, surgery, and OBGYN. We have 9.3, now total number is 33,000, and we have 9.3 for 100,000 population, and the standard ratio is 6, so we're okay with that. Dentists, we still have some to go. We have reached 9.6%, 9.6 per 100,000 population, while the standard is 11. Nurses, we have reached the standard, which is 117 per 100,000 population. We have reached 119. Midwives, we still have too little. We still are producing more. But so basically, we're okay. I'm optimistic that we will reach what we have set ourselves to do. Our main challenge at the moment are two, which is maldistribution and quality. And that is what we're working on now. Especially in remote areas, islands, the smaller islands, as well as the border areas, we still have lack of health providers. And by that, there are several interventions, which is, first of all, what we call the PTT. We are paying, the central government is paying for doctors, nurses, midwives, dentists, who are willing to be stationed in those remote and difficult areas, like other areas. While at the same time, the local governments are already producing, for instance, for medical doctors, we now have 72 medical faculties, which produce around 7,000 medical doctors every year, annually. So we'll be okay. And as you know, we are aiming for 2019 for total coverage. What about the health facilities? In primary care, as you know, our total population is 248 million, estimated for 2013. And at the moment, we have 9,581 public health centers and primary care, which is 3,239 with inpatient facilities, very small, less than 5 beds, but we have 6,342 just for outpatient. And this actually, again, if we talk about the ratio per 100,000 population, we have reached it. But our main concern at the moment is, again, maldistribution and quality. And here, I also have to share with you that we are not counting only on public health centers. We are working here with small private clinics. We are working with private doctors, especially family doctors, at primary care level. So That is why we are quite confident actually that we will be reaching this by January 2014. But again, the concern is about quality and maldistribution, and we're working on that. While for hospitals, actually, we are counting on one hospital bed for 1,000 population, which means we need about 250,000 beds. At the moment, we have reached it. If we calculate from government, we have 829 hospitals with 179,000 beds, and private hospitals, 1,309 we're working with. So the total number is almost 300,000, which means we have fulfilled actually the standard. But again, maldistribution and quality of care. And that is why, for us, for the national government, the priority is to help local governments build smaller hospitals for smaller populations in remote areas, on islands. These are smaller hospitals, which we call Rumah Sakit Purnama hospitals, with only 30 to 50 beds. So it's not big, but it has surgical facilities, OBGYN, röntgen, cardiology, etc. These are for the smaller population groups. As you know, one of our biggest challenges is the size of Indonesia, as well as these outlying smaller population groups who are living in hard-to-reach areas. We're also prioritizing what we call mobile clinics by land, by water, through the rivers, and also we have some, like in Papua, flying health care, but it's much too costly. I am not very eager to continue that, but we have to do it for now. But maybe some of you are interested in doing more of that. Finance, I think, again, everything is still in process. We are working on it. We have teams working, calculating. We have experts doing all that financial work. And also preparing transformation from PT ASKES to the BPJS, because by law it's stipulated that for the first 2 years, 2014 and 2015, this Social Security Agency will be carried out by PT ASKES, who has had more than about 20 years of experience and good governance and good financial management. Regulations also, we're still working on it. Most of it we have finished. We still have to do some for before the launch 2014. We still have to, we are still developing several regulations, and the rest will be done between 2014 and 2019. Human resources, as I said before, we have done the mapping, we have done the preparations. We are still, we think we are optimistic that we're going to reach what we have planned for, the roadmap, especially because we insist that we have to partner with the private sector. There is no way that the public health system only will be able to do it alone, and I don't think that's good. It has to be, we have to have public-private partnership. Of course, the private health sector may choose whether they want to join or not to join. That's their right. But by law, if you, as a private sector, have a hospital, then 25%, at least 25%, has to be allocated to serve the poor. So at least these 25% will join. But again, the private sector is free to choose. Then pharmaceutical and medical devices as well. We have done the analysis and found that in the jam Basmas, more than 60% were taken up by drugs, because drugs are so expensive. And we have a shift of the disease pattern from communicable to non-communicable diseases. And as you know, non-communicable diseases are very, very costly. Stroke, heart disease, cancers, renal failure, etc. all take up a lot of the funds. And so what we have done is for the drugs, set up a formulary. We talk with the pharmacists, gabungan pharmacy, they join to give us the best possible cost-effective drugs with the lowest price, but excellent efficacy. So that's what we have done. Also for medical devices, we have developed e-catalog, so that there is one thing that we do not need to do anymore, which is tendering, because we have not very good experience with tendering, corruption and all that. So now with accessing the e-catalog, we will get the price range which we have agreed to with the good, high quality drugs as well as medical devices. And for that we have a health technology assessment team in this task force. And that seeks, of course, socialization and advocacy. In conclusion, my friends, based on the Constitution, on the National Social Security System Act, and the Social Security Agency Act, Indonesian National Social Health Insurance, inshallah, will be launched on the 1st of January 2014. And the coverage of the social health insurance scheme will expand gradually, reach universal coverage by 2019. And implementation of the scheme calls for reforms in both delivery of health services as well as in health financing. They are underway to ensure smooth launch of the new system. So I look forward to your questions, inputs, and maybe also concrete proposals to be able to ensure that there is this public-private partnership. Thank you.
Thank you very much. Next to Dr. Nasfiah Mboi, Minister of Health, and I will give the podium to Dr. Fikri Isaac, Vice President of Global Health Services, Johnson & Johnson.
Good morning. Pleasure and an honor to be here with Her Excellence and the prestigious panel I'm sitting next to, and to all of you here attending this very important topic. It is really critical for us as companies on how we can make a positive difference in the world through the effort within corporate social responsibility, as well as addressing sustainability for the future. It is critical for us to also know how we can operate in a sustainable way with others in societies around us, and how can we ensure growth is inclusive for all people that we function with and operate in places where we operate. Many of you know Johnson & Johnson as the baby company. I'm sure in each household you have something that relates to Johnson & Johnson. And indeed, Johnson & Johnson has been taking care of babies around the world for the longest time, at least since I've been born. But we also, are actually involved not just in baby care, but the whole course, the life course. We're involved around the world in many areas, from consumer to medical devices, diagnostics, as well as pharmaceuticals. We market our product in 175 countries around the world and have over 130,000 employees that I have the pleasure and the honor of serving and helping them to stay healthy through their course within Johnson & Johnson, as well as after they leave Johnson & Johnson. I'm very pleased to say that we have been operating in Indonesia since 1973 and feel part of this beautiful country, and it is very critical for us to add positively in each week. When we talk about quality, and I think you heard it earlier today, our company actions around the world are guided by our value system, which we call the Credo. A document that was established in 1940 by the founder of Johnson & Johnson, General Robert Johnson. Really, the principle that we act on since then and continue to the future, and it is really about how our responsibility as a company takes the priorities. And as you can see, our first priority is to our customers, our patients, doctors, nurses, mothers and fathers that we service. The second is to our employees, the men and women that are working for us around the world. And certainly the third area where we are responsible is to the communities in which we operate and to the world community at large. And certainly we are confident that if we do all these three things right, we will have a fair share return to our stockholders. With that in mind, as we talk about the corporate, I went fast out here. Part of our citizenship and sustainability is how is inspiring our company, the humanitarian work we do around the world. We see our mission as making life-changing, long-term difference in human health by targeting the world's major healthcare-related issues. I am not going to spend time to talk to you about our sustainability, what we call the Healthy Future 2015 goals. All I can tell you, it is holistic. It goes beyond just focusing on the environment around us. It does cover from a global health, advancing global health, to partnering with our suppliers, to helping our employees live healthier lives and avoid injuries while they are working for us. It is about us improving the health of communities, about philanthropy work we do, about guarding and safeguarding the environment, and certainly it is about us being transparent and fair where we operate to our partners, our customers, and the countries we work with. You can certainly see more on the Healthy Future 2015 on the johnsonandjohnson.com website. Now, with regard to our giving, around the world we work through partnerships that deliver community-based solutions, and we focus on three key areas: saving and improving lives of women and children, a critical focus area for us; 2, preventing disease in vulnerable populations, addressing infectious disease where it needs to be addressed; 3 is strengthening the healthcare system as well as the health of our workforce and the workforce of our business, including government population. Let me close by focusing on Indonesia. We've been doing in Indonesia, and I'm not going to be able in the limited time to share some of those examples. They are in your handout, but I want to focus on a couple of things. If we look at maternal and child health, we've been partnering with Project Hope to educate community health providers who deliver essential medicines, newborn care, and emergency obstetric services. As Her Excellency indicated earlier, improving care will help Indonesia achieve its 2015 Millennium Development Goals, and we're certainly committed for the long term on achieving and supporting the Indonesian government in reaching those goals. Another area, midwife training, I know that showed as a gap in the previous slides that you have seen, and we certainly support the Bidan dilemma, who has trained 7,000 midwives on family planning, infection prevention, and safe delivery, with another 2,800,000 midwives receiving educational material, and so on. Now, it's not all about health within Johnson & Johnson. If we look at the work we have been involved here and partnering with for Kami, an NGO working on clean water, and how can we support 36 elementary schools in Jakarta to improve our next generation of people on how can they avoid issues pertaining to sanitation issues, as well as ensure the use of clean water as they grow and actually transmit that further to their communities and their families. There are more here to share, and we have several of other speakers who will talk about mental health and what we are doing in that field. But in the sake of time, I'm going to stop here, and I thank you for listening.
Thank you, Dr. Isaac. Johnson & Johnson and University of Indonesia has a partnership, especially in the mental health project, as it mentioned before. So now let's welcome Dr. Agung Kusumawardani from University of Indonesia.
Thank you for the opportunity. My Excellency, Ministry of Health, ladies and gentlemen, I am very honored to be here in this very important meeting. I would like to share our collaboration, partnership with Johnson & Johnson, One Heart, One Soul Mental Health Project. We built this collaboration from this fact where people with mental illness cannot get proper care and treatment because of lack of access, unaffordable or ineffective, or no information. Our objective of this project is to provide medical treatment and care, to ensure better treatment and care is given, to minimize the use of restraint to people with mental illness. Our target of this collaboration divided into two phases. In phase 1, in the year of 2012 until now, is the project with Traditional Shelter Galuh Foundation at Bekasi, West Java. And the second phase will do with the government social shelter Binalas Harapan Sentosa 2 Cipayu, East Jakarta. The activities start with a need assessment through qualitative and quantitative methods, doing training with the customer and the caregivers, training in 8 sessions for caregivers and 2 sessions for health workers, and then monitoring and evaluation this program, these activities, and then we achieve. The achievement is this kind of output. We have training and supervision module and 16 trained caregivers. And the most important thing from the Galuh shelter, we have 80 patients with proper and better treatment. And the outcome is better knowledge and skill with reducing negative perception about mental illness, better attitude toward people with mental illness, and this will reducing the restraint for mental illness. And the most important thing, right now their willingness to use medication for these people with mental illness. That's all. One heart, one soul. Thank you for listening.
Thank you, Dr. Agung. Now I will give the podium for Mr. George Matthew. Dr. George from Executive Dean of Pelita Harapan University, Faculty of Medicine. Thank you.
Hello everybody, and let me at the outset thank the organizers for giving me this opportunity to participate in this discussion. Although I'm used to giving lectures, I will keep it very short and just briefly mention to you that health is not just absence of disease, it's wholeness, and it is multifactorial. And so we need to recognize that industry and business can be involved in every way in promoting a healthy society. I recognize that one of the most satisfying and sustainable efforts in promoting health is to be involved in education, in medical care as well as research. I come from the University of Pelita Harapan, which is founded by the Pelita Harapan Foundation, which runs the Pelita Harapan University with its medical school, nursing school, and its research institute. Her Excellency was referring to the quality and the mismatch of supply of health professionals in Indonesia. And we have recognized it, and we are doing our best to create health professionals of excellent quality and competence. And we've also put in a strategy where we have students from distant and remote parts of Indonesia who then, after they qualify, will go back to their own native places for service. We are involved in both primary, secondary and tertiary healthcare. We have started an ambitious program of a general hospital based on what Her Excellency mentioned, purely on Jamkesmas and Jamkesta, and we want it to be a demonstration model where in the private sector we can make it viable, and not only viable, we can make it a thriving hospital service. We also provide tertiary hospital service with cutting-edge technology, not only in Jakarta or Java, but in many other cities of the world. We plan to start smaller hospitals, which Her Excellency explained, where we will have 40 to 50 beds, hospitals in the remoter areas, which will concentrate on mother and child and emergencies. We are also involved in community development. We plan to start in remote areas as remote as Papua. We are starting a project, novel project in Mamet in Papua, where it will be based in the school where a nurse and a community development worker will work together to try and improve the comprehensive health of the community. We have a research institute which is a non-profit institution and has been concentrating on problems unique to Indonesia. The three problems that we have concentrated on is hepatitis, colon cancer and liver cancer. So far we've been able to identify some unique molecular genetic predispositions in the Indonesian population. We still need to do work to make it realistic, whether it can be a future strategy for prevention and for cure. So thus, we in the University of Pelita Harapan have been involved in trying to promote health in a holistic manner through education, service and research. And thank you for your attention.
Thank you very much, Dr. Matthews. Unfortunately, the time is running out, so I have to say thank you to all the speakers here, especially Your Excellency, Mr. Mboi, Dr. Isaac, Dr. Agung, and also Dr. Matthews. Please, again, give a big applause for these speakers. Thank you very much. And also, I would like to give the stage to Vice Governor of DKI Jakarta, Mr. Basuki Cahaya Purnama. Thank you.
terhormat Ibu Menteri Kesehatan, Your Excellency from the Capital. Good, selamat siang, salam sejahtera untuk semua. Thank you. I am honored to be here. I think I have to speak in English. Yeah, the first, because of short of time, I just want to share about what the Jakarta government experienced with the TSR. We have many. Thank you for the Minister of Health. This year, we have tried to make the health coverage, insurance coverage, for the whole people in Jakarta. We don't care about how rich you are. If you want to get to the hospital, the third class, free of charge. Because we believe nobody want to use the third class room in the hospital. Because at bed with one bathroom, nobody like that. And that's why we make this a standard. We don't want to make a survey, you are worth it or not worth it. But I want to share today is about the resettlement. We face many problems like a flood, like a traffic jam, and especially the slum area. All of our 30 major rivers in Jakarta, most of them is occupied by the illegal housing. And we have made a mistake, I think, when we want to move them from this riverbank, we have to pay them. That's why everybody loves this situation. Even the water. You have to supply them with water with a very low cost fares about this fresh water. Only 1,000 rupiah. Maybe 10 cents. 10 cents in US dollar. And there are no limitations. They could use this water as much as they like to use this water. That's why we changed the law. If they use past more than 10 cubic meter, they have to pay $1. We don't care about this. That's why we face many little problems. But I want to show you what we have done in Waduk Pluit. Waduk Pluit is very important, like to control the flood area for the central Jakarta. We have a West Canal and East Canal. But like the palace and like a city hall and like the central Jakarta is controlled by this Waduk Pluit. But this Waduk Pluit is occupied by 17,000 people. 7,000 illegal housing. We have to move them. The problem is the central government also has the industry for fishery industry in this Muara Baru. They have 43,000 employees in this complex, and each day almost 5,000 ships to send fish to this industry. And this area is a very expensive area. It's an expensive real estate. So you could imagine how this employee, they want to live. That's why they occupy this riverbank. So what we have to do, we work with this Buddhist foundation from Taiwan. They develop on our land a low-cost apartment. They not only donate this low-cost apartment, they train the people. It's very difficult when the people live in the slum area. They could do everything they want to do. They have to move to this place, 1 floor, 10 units, some is 20 units. They have to share together. They have a habit to throw the garbage they just throw the garbage. But now there's a problem. That's why these Buddhists train them. We also have another complex. We have a 20 tower. This 2,800 units in this Marunda. Marunda is our future place. Mr. Governor, we want to make this place. We have allocated 400 hectares in this area. This area is the eastern side of Jakarta, and in front the beach, and north side is a new near the Tanjung Priok port. We have a brand in this place. People stay here. We not only provide them a housing, but we also provide them a job. This will decrease the traffic jam to make our transportation become better because they work and stay in the one place. We have planned this. We also train them. We provide them a fully furnished lower cost apartment. We provide them a TV, a gas cooker, a freezer, a dining table, and also spring bed. We provide to them this. All of this came from a CSR. If I have to buy this, we could not do this. There's more bidding, many procedures. But this in the very short condition, we need all of this fulfill all of this. So we ask many companies to help us. They provide one unit cost $600. $600. So they provide. Most of them is one unit or 1,000 units. We just depend on what they want to give to us. You could imagine there's 70 illegal housing. We have a target in 2 years. Most of them have to move to another place. But Mr. Governor told me, we not just get them out of this waduk, but we have to provide them a better housing. So we have to change their habit about how the way of life. We provide them, including the health concept. We want to build each apartment in the third floor. They have a doctor. We try in Penjaringan, they call it Penjaringan lower cost apartment complex. They have 9,000 people. When we work together with the Atmajaya Hospital, we want to put them a doctor there. So we want to try next year for capitation. So we hope in Jakarta, one doctor could control 3,000 citizens. So we could do this preventive and promotive. That's what we want to do. But we have a little bit of problem with the CBD's tariff. Because our hospital still in the class B. But RSDM is the top. So we have a 5 grade here. That's why we have a little bit of problem. We have sent a letter to the minister to increase our standard, our hospital standard, so we could get the good tariff. Like in road like this, when you clean the illegal housing, if you're waiting the government budget, have to bidding, everything like that, they will occupy it again. That's a problem. We send the police or the troop to guard this area. They need food every day. The same cost we have to spend. That's why we ask the CSR company to give us the road. I just met a Holcim company. They told me have a new technology. The cementing road could absorb the water when the rain comes. But this still use the old technology, could not absorb the water. There's also many pumps. Japan government also helped us to develop a new pumping. And also many companies to help us to control this pumping house. Because we need like like a bapak angkat, you know. Adoption father. Father. Okay. Of course, the father. Sorry. My English is not good. So they could control the pumping. We found almost 200 pumps in the whole Jakarta is broken. That's why what happened in Pademangan, Ancol, they have 3 pumping machines. 2 of them already broken since 2 years ago. And this is a central government home station. That's why we send a letter to them. Just give to us. We try to find what company want to do this TSR. There are many, including the Puskesmas or local hospital. We got helping from railway consultant. First, they help us, including the Australian heads, to help us to make a study. What's going wrong with our Puskesmas? So they come there, they help us. Now we want to train the people, the one city, how to do the good service for the people. We need the money to do this. If we use a bidding, need the time, and sometimes who win this project is not a professional. That's why we prefer to ask the company. I just try to persuade the cigarette company. I told them, I already reject their proposal to help us for a rainwater harvest. In Jakarta, many slum areas, they lack of the fresh water. Many elementary schools, they don't know how to wash their hands. So we work together with the medical faculty, Cahaya and University Indonesia, to work together to train the children, the school children in our elementary school for 1 year. That's why they need, this is a big bunker for water. The first is a cigarette company want to provide all of this. But they want to put the cigarette in the bunker, you know. And I said, excuse me, no. And I also met Johnson & Johnson in Indonesia. I said, this is good for you to do this, not the cigarette company. And about the cigarette company, we are not the president. We could not ban. We don't against the smoker or cigarette. We just want to control the smoke. We just want to control this. That's why I said, how about if you pay the consultant to help us to make a training for our local hospital, how to serve the people, to make a system. I don't know the boss agree or not, because he went to the United States for a holiday. But I think he happy because he talked three hours with me, 3 hours. I hope when he came back from the States, he will provide this. I think this also from the CSR. Some of the heavy equipment company, they want to sell the product to us. So I give them a suggestion like this. It's better help us first to show you unit is good. So they agree for work without payment 3 months. I make a promise, if your heavy equipment is good, I will buy the same brand with you. So they happy. I'm not cheating. I just talk the serious. Yeah, just honestly, I offered to them. This is also for the garden. We spend billion rupiah for many gardens. This is a problem. That's why I cut the budget. People don't need this budget spent for this garden. It's better this budget for education, for health, for housing, for transportation, for opportunity to sell their creative products. We need many places for showroom. It's like an incubator. When we help the people to create the product, we have to provide them a place for the showroom. That's why this year we still make a detailed engineering design in our national monument. We want to make the underground property to provide this. We have to make a connection with the Gambir train station and also with our busway. And we hope we could make a 4 underground with our MRT from Lebak Bulus until the north side is Kampung Bandar. We hope this becomes a transit-oriented development area underground. We want to provide all the Jakarta when they have an opportunity to show their products. And this garden now, most of the garden in Jakarta now from CSR. They put their brand from the carpet stone. This is from what group, what kind of group. Yeah, we don't care about it. We just put it. We just care, we save the money for more benefit to the people. The other side, we need a good environment like this garden. You could imagine, this is Angke. Most of the river like this. And most of them, not all this, some areas, they rent from, we call it a Fender Street property company. And you never imagine in Jakarta, they have a toilet, restroom, boss, drive a Mercedes-Benz 2 doors, not a bus, 2 doors, sport, not a bus. This is a 2 doors Mercedes-Benz. They rent all of this restroom to all of these people that got a lot of money. Now like this, when they clean, the seat pile from all like it. Seat pile, these people make all like it. But cleaning, we also offer to the people, you have equipment here, you put your brand for maintenance of river. We have a 60 river, 13 is a major river. That's why we ask them, just put your heavy equipment, put your brand, and do this maintenance, including the bus. We just talked to, we had a lack of bus, Grand Jakarta. We never enough to provide the bus. That's why people have to wait until 2 hours. Many companies, they want to provide us a bus, articulated bus. They put their brand. And we said, when you give to us as a GSR, you don't need to pay the tax because this bus is on the government. And you just make a road each year, you have to renew the painting. This means you have advertising free of charge. Now they have ordered 30 bus, articulated bus. And we hope in the end of this year they could supply to us. I think we have many problems in this housing. What we targeted in 2 years, we want to make the river normalization accomplished. That's why I told the World Bank, if you give us 5-year program, you just go back to your country. We did in 2 years. You know why? In 5 years, many people will get the money 5 times. You pay them here, they move to another place. Next year, you got the payment again. Next year, you get the payment again. We said no. We have to change the law. The rule of give we have to change. If you say you don't have a house, we provide to you. But the people to get the money from this situation, they get nothing. Now most of the some area house is owned by many people. They own an 8 house or 12 or 20. They rent to the people. That's why this is a little bit problem. What Mr. Governor told me, we don't have other choice. Jakarta, we know everything, Jakarta. Many study about Jakarta, what the problem, what the solution. Everything accomplished. When you're talking about transportation, when we entered the office, I found 22 studies about transportation. So what's wrong here? Because we just need to execute this program. Like the MRT, I will show you. Why MRT program, this is a metro train, subway, has a problem. We need at least 5 years to accomplish half route. You could imagine the traffic jam will happen when this MRT is on construction. Our time period in office only 5 years. I have been in office for 8 months. If we decided at the end of this year to the groundbreaking, that means 2017, when we want to run again to this office, this project still 4 years. That means maybe in 4 years, the Jakarta residents curse us every day. And that means we could not be elected again. Yeah. That's why nobody wants to start this project. 20 years already about this MRT project. But the governor and he said we have to start. Even 2017, nobody want to vote for us. We have to establish the foundation about the housing, lower cost apartment, about the education, about the health program, about the small scale enterprise, about the transportation. We don't care. We still have 52 months in office. We will do our best for Jakarta. Thank you.
Thank you, Pak Ahok, for your remarks. And ladies and gentlemen, we will now take an hour-long break for lunch to provide you with a networking opportunity also. For all the speakers of today's session, your lunch will be served upstairs, and so will the press conference. Our ushers will guide you there. We would like to invite everyone to please clear the room while the hotel staff will set up for lunch. Lunch will be served back here in the ballroom. In approximately 10 minutes, we will open the doors again to the ballroom for everyone to return to their seats for lunch. If during registration you choose the vegetarian option for lunch, please leave your lunch card on the table in front of your chair. This will indicate your hotel staff to provide you with a vegetarian bento box. We encourage you to make the most of this next hour to network and enjoy the opportunity to meet others who are focused on similar professional